this morning with Dr. Dan Edney, the State Health Officer with the Mississippi Department of Health. Good morning, Dr. Edney. Thanks for joining us.
Good morning. My pleasure. I appreciate the opportunity.
Yes, sir. So the state of the healthcare industry, and in particular the financial condition of the hospitals in the state of Mississippi, has been in focus, shall we say, over the last year at a minimum. What's the latest? What are you hearing from the hospitals out there, those responsible for making the numbers work in particular? I mean, you still have to worry about that, even though the primary business, of course, is curing disease and taking care of people and getting them healthy and preventing disease. And
that's
and
what it's all about.
Yeah, prevention. Of course, I know you're a big proponent of that and very outspoken about that. And there's so many great ways to do that these days. It's just a matter of execution, I guess, and adherence. But what's the status? How are we looking?
Oh, it's a mixed bag. Still a lot of severe challenges, especially in the Delta and Southwest Mississippi. The Gulf Coast is in a healthier environment. Pine Belt tends to be doing better. The far northeastern corner of North Mississippi is doing well. The Memphis suburbs, so it's kind of sporadic.
Okay.
But no one is knocking it out of the park right now, and we have really a spectrum of hospitals that literally see their drop dead date ahead of them if something does not happen.
Financially speaking.
Correct.
Yeah.
And then, hospitals that are doing okay, but they're burning cash reserves, which, they're still significant, but you can't sustain that indefinitely. All the way to hospitals that are doing okay and making a little money. Nobody, right now is not the time to be investing unless you're buying low in Mississippi healthcare. And the thing I try to remind people is it's not just rural hospitals, especially, it's rural healthcare. Our doctors, our providers in rural Mississippi are struggling. It's very hard to recruit into rural Mississippi right now. The nursing shortage is impacting the whole state, but it's hyper acute in the rural areas. And, patients in rural Mississippi are struggling to have access to care the way they should, the way you and I do in more affluent areas of the state.
What strikes me about your overview there, Dr. Edney, is that when you talk about, there's some in this area of the state that are faring okay, but there's some in this other areas of the state that are really in very challenging circumstances. What's the distinction? What makes one, successful, if you could call it that, or certainly not on the brink of failure, and one that's it seems imminent?
Yeah, and it's multifactorial, as you well know, because I know you study this. When you look at the regions of the state, when you look at the Mississippi Delta, the infrastructure is struggling. The investment in healthcare is very low. The population shift is negative, so out-migration from the Delta. And the Delta has the highest rate of uninsured for the state with the highest rate of uninsured. So the Delta is like the concentration of all the struggles we're having in healthcare is magnified there. But then I have to remind folks, Southwest Mississippi is right behind them. Natchez, Macomb area, doing okay, not great, but okay. The rest of Southwest Mississippi is struggling mightily. And one way I'm able to watch that is as I watch what are happening to services being provided, not just by hospitals, but by physicians and other providers. And, as I see multiple hospitals in the Delta, at least one, probably two or three in Southwest Mississippi that are shifting to downgrade to rural emergency hospital status, that speaks volumes when they are giving up on inpatient work.
Okay. Is it a function, when you describe it that way, the first thing that comes to mind is I think about just the income levels of the population. Right. And so what you're saying is that areas of the state where the income levels are low are where the healthcare institutions are most struggling. And that seems to add up. So I'm assuming that if you look at, say, the Gulf Coast, maybe pockets of northeast Mississippi, I know the hospital in that area seems to be doing better than most. And then, of course, here in central Mississippi, kind of have a mixed bag as well.
We do. And if you look at just, say, the Metro Jackson hospitals, very mixed bag.
Well, they're not doing great either, honestly.
Absolutely.
I mean, they're upside down cash flow wise.
And, Merit Health has made no secret that the only reason they're still, at Merit Central is they have to be by contract, by lease. And this is a dynamic shift, so it's not static by any means. But that, when things are dynamic, it means it can move both ways. So there are solutions, and I'm optimistic that some of the things the legislature did last session hopefully will at least stabilize the situation or stabilize those who are in most danger right now.
So I see a lot of finger pointing. I've shared with you before. I'm acquaintances with a lot of folks in the industry that are higher levels and some of the big hospitals in the state. And there's a lot of finger pointing. What I mean by that is it's a unique industry in that there are a lot of parties involved in the transactional side of things because you have a third-party payer. Right. And that just
hopefully.
Right. Hopefully you have a payer period, right? But that complicates, and that's unique. Most other industries, I can't think of another one, honestly, where you have that situation where there's another party inserted in the transaction. In this case, healthcare insurers. But the healthcare insurers seem to point to the medical providers as their problems for causing their woes, financially speaking. And then you got the healthcare providers that say, well, the insurance companies are making all the money. And as a result, we just seem to be at a standoff, not really solving the problem.
Although I saw a change in tune and definitely tone as the conversation progressed through the session this year, that really I think everybody understands that we have a problem. As an addiction doctor, step one is admit we have a problem.
Sure.
And I think everybody gets it.
Okay. I would agree with you.
We have a problem.
There seems to be more acknowledgement that there is a fundamental structural problem. And as you well know, it's not limited to Mississippi.
No.
I mean, it's a problem across the country.
That's right. What I do because my job is to look at population health and to look at how things are for our entire 2.9 million population. And a lot of that I do by comparing our population to our region. We're so far behind our region. Even though we have other areas of other states in our region who have challenges, no one has the challenges that we have.
And what do you attribute that to?
Poverty drives everything in Mississippi. I grew up in Greenville, and I was the youngest child of low-income Delta workers. So I've tasted it. Didn't have health insurance till I graduated, till I actually went to work as an adult. And we were not impoverished. We were low income, but we were not impoverished. But we have such a high percentage of impoverished Mississippians that gets in the way of everything. It gets in the way of just simple public health measures. It gets in the way of having medical homes so that people can get their colonoscopies when they're 50. We have too many diabetics and hypertensives walking around that don't have a clue they have it until they get sick. All of these, poverty gets in the way of everything, and there is no, silver bullet for poverty except continue to improve our economic standing in the region as we have been working towards. But we are so far behind Alabama, Tennessee, even Arkansas. I mean, for Pete's sake, when we're behind Arkansas.
Yeah, absolutely. Can you stick around?
Sure.
Yeah, we've got Dr. Dan Edney, the State Health Officer, in the Element Well Studios. We'll continue this discussion about the state of the healthcare industry in Mississippi when we return. And we've got Dr. Dan Edney, the State Health Officer. We're just talking about the state of the healthcare economy. That's how it's referred to on a formal basis when we're talking about the national healthcare industry, the HCE, as I recall, the acronym, but we could apply that here within the borders of our state as well. There are some people, honestly, Dr. Edney, that believe that there's more to this story, that the hospitals really aren't struggling financially, that they're like hiding something, or that they're just overweighted with extraneous, unnecessary administrative costs that they could shed and fix everything. Well, certainly I agree that every organization should be constantly looking to improve efficiencies and operate optimally in that perspective, but and they should be doing that. And if they're not, well, then shame on them. But we got a revenue problem. When I hear my various friends in the industry talk about, well, yeah, it's a lot of services that we get, we just don't get anything for. We get no compensation, no reimbursement. How does an industry make ends meet, produce a cash flow, when they're having to give away so much of their work product?
And they're mandated to give it away.
Right, true.
So it's not, and they don't have a choice in the matter. In the old days, let's move back to healthier times and healthcare economics in general. Let's go back to 2010.
Okay.
If you go back to the 1980s, there was so much money flowing through healthcare just from Medicare. Those are back in the days when Medicare was the golden goose. And nobody had balance books back then. There was plenty of money.
Yeah.
And then the 90s is when managed care started coming in and Medicare started tightening down. And then in the early 2000s and into the teens, it got worse and worse. Healthcare always balanced their books based off private insurance and Medicare.
Yeah.
And that's how they could take care of the uninsured and Medicaid. Those days are gone. Medicare barely pays the bills. It may be a 1% margin, maybe. Medicaid does not fully pay the bills, but it's better than nothing. So when I hear this argument that Medicaid makes things work, you don't understand healthcare economics, because we're talking about putting money into a bucket that's empty. That's better than nothing. And you have insurers like Blue Cross that now dominate the market, who they don't negotiate with anybody.
Right.
And so it's a whole different economic world, and those margins aren't there like they used to be. So
is it accurate to say then that the hospitals in Mississippi that are, let's say, doing better than others, it's could be attributed to the fact that much of the care they provide is covered, reimbursed by private insurance as opposed to Medicare, Medicaid, and of course they typically have a low amount of unreimbursed care.
That's right. We have it, and the Delta, there are counties that have a 15% uninsured rate, and then the rest of it's virtually all Medicaid, Medicare with maybe 8% private insurance. Those numbers don't work for anybody. And we have areas of the state where you flip all that, where you only have maybe 4% uninsured.
Yeah.
And
Oxford is one, is it not?
It is. And in fact, Oxford, there are areas around the Delta that benefit from their location because there are those with private insurance who will leave the Delta to go get health care outside the Delta.
I see.
Oxford is one of those communities. Clarksdale's like a beeline straight to Oxford. And but most of the state, you're looking at around 7 to 8% uninsured, with a balance of private insurance about 7 to 8, maybe up to 12%. But again, Medicare, Medicaid filling in the middle, and Medicare and Medicaid just doesn't generate profit like they used to. So you've got to get it from private pay or private insurance to generate a profit. And now, healthcare providers, again, don't throw doctors and providers out of the mix. Everybody's looking at just being sustainable.
Right. Well, analyses I've read, and there are different ways to approach it, but sometimes show that Medicare is upside down, that's actually below cost. I mean, you said maybe a 1%. I've seen some that say it's actually below cost. Medicaid, I don't know if Medicaid ever covered costs.
Never
It's the
was
program.
Was not the intention.
That wasn't the intention.
It was to provide health insurance for the lowest income Americans and to provide some compensation to those who were providing that care.
Yeah, for certain limited coverage groups.
That's right. And Mississippi probably has one of the most limited coverage groups in the nation. We have to face the reality that economics and everything are different in the 21st century. But the government money does not flow like it used to. Our federal funders, and everybody has to understand, the feds dictate health care compensation in this country. They control everything.
Yep.
And the state does its part through our Medicaid match, which is our part is the lowest in the country. But the feds have made a decision. They're funding at the level they're going to fund. They're not pushing more revenue into the pipeline. Here's what's on the table. You can take what's available to you or not. They don't much care. And if you don't take it, then, God bless, go do the best you can.
Explain for the benefit of our audience, Dr. Edney, what disproportionate share payments are, the DSH payments.
Yeah, the DSH payments historically made up for those areas of the state that had a higher burden of Medicaid patients, and also to help with the uninsured issue. Because, Oxford just doesn't have the same number of Medicaid patients that Clarksdale does.
Right.
And so to kind of balance it, through the Medicaid program especially, the federal government would push it's almost like bonus payments for taking care of that population to kind of balance the books somewhat.
Right.
To keep you from being punished because you were seeing Medicaid, and actually try to help you see Medicaid patients.
So one thing I would recommend.
And that's gone way, way down.
It's gone down. And in fact, I'll hit this in a minute. The Biden administration wanted it to go down even more.
It did.
And that was to force the states, the 11 remaining states that haven't expanded Medicaid, to expand. Because that's something that I would recommend to the proponents of Medicaid to not just discuss the amount of money that would flow to the state. It's roughly $1 billion, it's estimated, if we expanded Medicaid, which would just be adding a coverage group. That's something else I think is widely misunderstood. We're just talking about adding a coverage group, not increasing the amount that the state receives from the Fed for the existing coverage groups. It really doesn't do that. It primarily just adds a coverage group that's able-bodied adults with a certain income, low incomes. Yeah. But there would also be a reduction of DSH payments if we expanded Medicaid. So there's a net in there. It makes sense to me, Dr. Edney, that the proponents of Medicaid expansion would show us those figures so we know what the true net effect would be.
Yeah, and to be honest, I don't know. That's a great question. Kind of my philosophy is, we have a revenue issue in the healthcare system in general. We can either put the money into the hospitals, or we can tie the resources to the individual patient, who will then choose where they want to go. Yeah. Kind of a conservative principle is, make the industry produce so that people will want to come to you by incentivize the customer. Yeah. And for us, that's the patient. And right now, patients are just trying to get in wherever they can.
I know you talked about this with Paul Gallo a couple of weeks ago, but this grant program established by the legislature, it was subsequently determined that there's some strings attached because it's being funded by some federal COVID funds, and for the most part, it's designed to cover excess COVID expenses, and a lot of the hospitals said, well, we've already been reimbursed to cover for that, so we don't really have access to this grant. What's the status of that now?
We're off to a good start. We have, as of yesterday, 10 hospitals who have applied, and they've pretty much gotten they're working really well on the front end to get the right information to us that we need so we can process quickly. ARPA funds, as you know, are not meant to generate profit for anybody, but to kind of stabilize things. Yep. So there is a lot of, with the applications we're seeing, there's a lot of opportunity to get a lot of money out.
Okay. $104 million.
Yeah.
I think was the amount of money. But that's a drop in the bucket relative to the revenue losses that are being experienced.
Yeah, I'm glad to see it. It's going to be helpful. It doesn't fix the problem.
Gotcha. Appreciate you coming in.
Oh, my
Dr.
pleasure. Anytime.
Good time. All right, we'll step aside for a break right here. Coming right back with more in the Element Wealth Studios.